Good afternoon everyone, myself Dr. Saeed Vora. Today we will be talking about arterial blood gas interpretation and the clinical implications. This is the normal arterial blood gas values, the pH of 7.35 to 7.45, a CO2 of 35 to 45 mmHg and a PO2 of 70 to 100 mmHg on the room air. This is the predicted PO2 with the inspired FiO2 relation. If a PO2 is less than 4 to 5 times the FiO2, probably the patient might be hypoxemic at a room air. Conditions which may invalidate the ABG results are the delayed analysis, the external temperature, excessive heparin, air bubbles, patient's temperature and the type of the syringe. If the sample is kept too long, then the consumption of the O2 and production of the CO2 continues after blood is drawn into the syringe. This may lead to the decrease of O2 and increase of CO2. A ice sample can be maintained for 1 to 2 hours, whereas an ice sample quickly becomes invalid. So PO2 decreases at a rate related to the initial value and dependent on the HB saturation, and CO2 increases every 3 to 10 mmHg per hour. This slide shows how the pH changes with the external temperature. At 37 degrees Celsius, the pH decreases 0.01 by 0.01 value every 10 minutes, whereas if at 4 degrees Celsius, the pH decreases by 0.001. The same is with CO2. CO2 increases by 1 mmHg every 10 minutes at 37 degrees Celsius, and it increases by 0.1 mmHg at 4 degrees Celsius. At PO2 decreases by 0.1% every 10 minutes at 37 degrees Celsius, and it decreases only by 0.01% at 4 degrees Celsius. If there is excessive heparin in the syringe, then this may alter the results of bicarbonate and CO2. Bicarbonate decreases and CO2 also decreases. The syringe should be emptied completely after flushing. The risk of the alteration of the results increases with the increase in size of the syringe or the needle and decreased volume of the sample. Hence, syringe should be greater than 50% full with blood sample. Air bubbles. Normally, the air bubble contains a PO2 of around 150 mmHg and almost negligible CO2. So, mixing the sample with the air bubble leads to movement of the PO2 towards 150 mmHg, and it decreases the CO2 values. Mixing or the agitation of the sample, which leads to increase in surface area for the diffusion, and hence more erroneous results will occur. Discard the sample if there is excessive air bubbles or the froth, and you have to seal with cork or cap immediately after taking the sample. Now, temperature of the patient. Most ABG analyzers will report the data at a normal body temperature. If the patient is severely hypothermic or the hyperthermic, the values of pH and PCO2 changes significantly. However, if the patient's temperature is less than 37 degrees Celsius, subtract 5 mmHg of PO2, 2 mmHg of CO2 and add 0.01 to pH per 1 degree decrease of temperature. There is no significant change in other parameters. However, there is no consensus regarding reporting of ABG values, especially pH and PCO2, after doing the temperature correction. Values other than pH and PCO2 do not change with temperature much. Hence, patient's temperature should be mentioned on the sample. Type of the syringe. Usually we use the plastic syringe. However, there are some advantages with the glass syringe because there is a minimal friction of the barrel with the syringe wall. There is no need to pull back, and hence less chances of getting air bubbles. Also, in plastic syringe, there is a small air bubbles will adhere to the wall of the syringe in plastic syringe, which are difficult to expel. Though the glass syringes are preferred, but the difference is very negligible. So, plastic syringes can be used and continue to be used. Regulation of the arterial pH. Now, the pH is regulated by buffers present in the system. The presence of buffers system minimizes the change in pH resulting from production of acid and provide important protection from acid load. The main buffer system of the body is bicarbonate, which combines with H plus ions to form bicarbonic acid, which splits into H2 and CO2. The role of the respiratory system is to elimination of the volatile acids like carbon dioxide, CO2. Respiratory centers in the brain respond to the change in pH of the CSF and blood to affect the ventilatory rate. Ventilation directly controls the elimination of CO2. The role of the kidney. The role of the kidney is to retain and regenerate the bicarbonate, thereby regenerating the body buffer with the net effect of eliminating the non-volatile acids like ammonia, phosphates. The maximum bicarbonate absorption occurs in the proximal tubule, 90%. 90% of the absorption occurs in proximal tubule. Factors which affect the H plus secretion or reabsorption of bicarbonate is CO2 concentration, pH, aldosterone, extracellular ECF volume, potassium concentration, and the chloride, anion gap. Now, anion gap traditionally is used to assess the acid-base status, especially in the differential diagnosis of metabolic acidosis. The change in anion gap and change in bicarbonic acid is used to assess the mixed acid-base disorders. Now, anion gap is a difference between unmeasured anions and unmeasured cations, which is equal to sodium minus bicarbonate acid plus chloride. Now, these are the list of unmeasured anions versus unmeasured cations. The major unmeasured anions are the albumin, organic acids, phosphates, sulfates, and cations are calcium, potassium, magnesium. So, the normal anion gap value is around 12 to 4, which is revised to 8 plus or minus 4 milliequivalent per liter due to changes in methods of measurement of sodium chloride and bicarbonate and resultant shift of chloride value to a higher range. Hypoalbuminemia. The patients with hypoalbuminemia means low serum albumin will have normal anion gap even if there is a severe metabolic acidosis, because albumin is a main unmeasured anion. Alkalosis. Alkalemic patients with pH greater than 7.5, anion gap may increase due to metabolic alkalosis per se, because increase in pH, metabolic alkalosis leads to increase unmeasured anions by surface charges on the albumin becomes more negative in alkalemic conditions. Also, there is a volume contraction with metabolic alkalosis, so there is a hyperproteinemia, and also there is an induction of glycolysis which leads to the hyperlactatemia. So, in metabolic alkalosis, alcoholic patients may have higher anion gap due to metabolic alkalosis per se. Hypercalcemia. The fall in anion gap is expected because there is an increase in unmeasured cations. The drugs like lithium and polymyxin will cause fall in anion gap because unmeasured cations increases, while carbamazepine causes increase in anion gap. Higher clearance of the anions as occurs with decay patients in the early stage. The patients with they may be expected to have a higher anion gap acidosis, but still anion gap may come to normal because of the higher clearance of the anions. The difference of anion gap and bicarbonate acid relationship is if the difference of anion gap, the ratio of difference of anion gap to bicarbonic acid is 1 to 2, then it is a pure high metabolic anion gap acidosis. If the ratio of difference of anion gap to the difference of bicarbonic acid is greater than 2, then it is associated with metabolic alkalosis. If the ratio of difference of anion gap to bicarbonic acid is less than 1, then it is associated with normal anion gap metabolic acidosis. Bicarbonate. The standard bicarbonate levels is measured in lab after equilibration of blood CO2 to 40 mmHg. And actual bicarbonate levels are calculated from pH and CO2 directly. It is a reflection of non-respiratory, that is a metabolic component of acid-base status. It is calculated from pH, CO2 and hematocrit. It is expressed as milliequivalent per liter of base above normal buffer base range. Negative base excess also is referred to as base deficit. It is a true reflection of metabolic component of acid-base status. Now, these are some of the terminology: acidosis and alkalosis, respiratory, metabolic, compensated, uncompensated. Now, acidemia is when the reduction in the arterial pH is less than 7.35. Alkalemia is when the increase in arterial pH is more than 7.45. Acidosis is the presence of process which leads to decrease of pH by virtue of gain of H plus or loss of bicarbonate. Alkalosis is a process which tends to increase the pH by virtue of loss of H plus or gain of bicarbonate. Now, whether it is a respiratory or metabolic, respiratory process which leads to acidosis alkalosis through a primary alteration in ventilation and resultant excessive elimination or retention of CO2, whereas metabolic processes leads to acidosis or alkalosis through their effects on kidney and the consequent disruption of H plus and bicarbonate control. Compensation. The normal response, this is the normal response of the respiratory system or the kidney to a change in pH induced by a primary acid-base disorder. Simple versus mixed acid-base disorder. Simple acid-base disorder is a single primary process of acidosis or alkalosis, whereas mixed acid-base disorder is the presence of more than one acid-base disorder simultaneously. Now, these are the characteristics of the primary acid-base disorder. If it is a metabolic acidosis, there is a primary response is gain of H plus ions, which leads to decrease in pH and decrease in bicarbonate, and it is compensated by the body by decrease of CO2. Metabolic alkalosis, the primary process is decrease of H plus ion and increase in pH with increase in bicarbonic acid, and it is compensated by body by increasing the CO2. Respiratory acidosis has increased H plus, decreased pH and increase in CO2, which is compensated by body by increasing the bicarbonate levels. Respiratory alkalosis has decrease of pH, decrease of H plus ion, increase of pH, decrease CO2, which compensated by body by decreasing bicarbonates. Compensation in the presence of acidosis or alkalosis, the regulatory mechanism occur which attempt to maintain the arterial pH in a physiological range. The compensation process results in return of pH towards the normal, but generally it is just outside the normal range. A disturbance in bicarbonate, either metabolic acidosis or alkalosis, results in respiratory compensation, while changes in CO2, respiratory acidosis or respiratory alkalosis are counteracted by the renal compensation. Renal compensation usually takes 2 to 5 days, whereas respiratory compensation occurs immediately. Now, this is the normal range of the compensation. If the primary disorder is metabolic alkalosis, then the CO2 decreases by 1.2 mmHg per 1 milliequivalent decrease in bicarbonate. If the primary disorder is metabolic alkalosis, then the respiratory compensation is by increasing 0.7 mmHg of CO2 per 1 milliequivalent per liter increase in bicarbonate. If the primary disorder is respiratory acidosis, in acute condition, bicarbonate increases 1 milliequivalent per liter per every 10 mmHg of CO2, and in chronic respiratory acidosis, bicarbonate increases by 4 milliequivalent per liter for 10 mmHg of increase in CO2. In acute respiratory alkalosis, bicarbonate decreases by 2 milliequivalent per liter for every 10 mmHg decrease in CO2, and in chronic respiratory alkalosis, it decreases by 5 milliequivalent per liter per 10 mmHg decrease in CO2. Now, interpreting the pH. The normal arterial pH, as we all know, is 7.35 to 7.45. If it is less than 7.35, then it is acidosis, and if it is more than 7.45, it is alkalosis. Metabolic conditions are suggested if the pH changes in the same direction of CO2 or bicarbonate, and respiratory conditions are suggested if the pH changes in the opposite direction to CO2 or bicarbonate. Now, these are the 7 steps which are highly successful in blood gas analysis. The step 1 is looking at the pH. If the pH is less than 7.35, it is acidemic. If it is more than 7.45, it is alkalemic. Now, to determine, the step 2 is to determine whether it is metabolic or respiratory disturbance. Now, if there is acidemia with bicarbonate less than 20 millimoles per liter, it is metabolic. And if it is acidemia with PCO2 of more than 45 mmHg, then it is respiratory. If it is alkalemia, that is pH more than 7.45, even if bicarbonate is more than 28 millimoles per liter, it is metabolic alkalosis. And if pH is more than 7.45 with CO2 of less than 35 mmHg, then it is respiratory alkalosis. The step 3 is to determine whether the it is a primary respiratory disturbance or is it acute. If the primary disturbance is acute, is respiratory, whether it is acute or chronic, it is the third step. Expect the change in pH change in pH of 0.02 into CO2 by 10 if it's acute, and if it's chronic respiratory disturbance, expect the change in pH as 0.03 into change in CO2 by 10. The step 4 is to determine whether the renal compensation is okay or not. If it is respiratory acidosis is less than 24 hours, then change in bicarbonate is expected as 1 by 10 of change in PCO2, and if the respiratory acidosis is more than 24 hours, then a change in bicarbonate expected is 4 by 10 into change in CO2. If the respiratory alkalosis is 1 or 2 hours, then a change in bicarbonate is expected by 2 by 10 of change in CO2, and if it is more than 2 days, then a change in bicarbonate is expected by 5 by 10 of change in CO2. Now step 5 is to determine whether the respiratory compensation is appropriate for metabolic primary disorder. For metabolic acidosis, the expected change in CO2 is 1.5 into bicarbonate plus 8 plus or minus 2. For metabolic alkalosis, the respiratory compensation expected is zero 0.7 into bicarbonate plus 21 plus or minus 1.5. If the actual PCO2 is more than expected, then there is a hidden respiratory acidosis, and if actual PCO2 is less than expected, then it is hidden respiratory alkalosis. Now step 6 is, if it is a metabolic acidosis, is there any anion gap? Anion gap, as we all know, is the formula is sodium minus chloride plus bicarbonate, which is usually 8 to 12 milliequivalents per liter. If anion gap is more than 12, then it might be methanol poisoning, uremia, diabetic ketoacidosis, paraaldia poisoning, infection, ethylene glycol poisoning, or salicylate poisoning. The step 6 is to determine, does the anion gap explain the change in bicarbonate. The change in anion gap, the relation of change in anion gap is almost and change in bicarbonate are more or less the same. If change in anion gap is greater than the change in bicarbonate, consider additional metabolic alkalosis. If the change in anion gap is less than the change in bicarbonate, consider a non-anion gap metabolic acidosis like hypochloremic acidosis or DKA in early stage. Mixed acid-base disorders. Mixed acid-base disorders are very common in chronically ill respiratory patients. In renal failure, combined metabolic alkalosis and metabolic acidosis is also encountered. Hence, we also always look about mixed acid-base disorder. Now, tips to diagnose a mixed acid-base disorder. The tip 1 is, don't interpret any blood gas data for an acid-based diagnosis without closely examining the serum electrolytes like sodium, potassium chloride, and CO2. If a serum CO2 is out of normal range, always represents some type of acid-base disorder. If a high serum CO2 indicates metabolic alkalosis and or bicarbonate retention as a compensation for respiratory acidosis. Low serum CO2 indicates metabolic acidosis and or bicarbonate excretion as a compensation for respiratory alkalosis. So serum CO2 may be normal in the presence of 2 or more acid-base disorders. The tips 2 is a single acid-base disorder does not lead to normal blood pH. Although pH can end up in a normal range 7.35 to 7.45 with a single mild acid-base disorder, truly normal pH with abnormal CO2 and bicarbonate invariably suggests 2 or more primary disorder. Tip 3 is simplified rules to predict pH and bicarbonate for given change in CO2. If a pH and bicarbonate is higher or lower than expected for the change in CO2, as explained in earlier slides, the patient probably has metabolic acid-base disorder as well. Now, predicted changes in bicarbonate for directional change in CO2 also can help in uncovering the mixed acid-base disorder. A normal or slightly low bicarbonate in the presence of hypercapnia suggests concomitant metabolic acidosis. Similarly, a normal or slightly elevated bicarbonate in the presence of hypocapnia suggests a concomitant metabolic alkalosis. The tip 4 is, in maximally compensated metabolic acidosis, the numerical value of PaCO2 should be the same or close to the last 2 digits of the arterial pH. Now SO2. Now SO2 is the saturation, oxygen saturation of hemoglobin. Is it calculated or measured? In modern ABG machines, the co-oximeter is combined with the ABG machine, so usually it is measured. Now, carbon monoxide and methemoglobin poisoning does not affect the PO2, but they do affect the saturation of arterial saturation. Now, carbon monoxide. Normal percentage of carbon monoxide in blood is 1 to 2% from metabolism, and a small amount of ambient carbon monoxide is there in the heavily traffic congested areas. All smokers have excess carbon monoxide in their blood, typically 5 to 10%. Carbon monoxide binds 200 times more heavily to the hemoglobin than O2. Carbon monoxide does not affect PO2, however, it affects arterial saturation. To detect carbon monoxide poisoning, SaO2 or carbon monoxide must be measured, which is usually done in modern ABG machines. In the presence of excess carbon monoxide, the SO2 when measured will be lower than expected from PO2. As we all know, carbon monoxide does not affect PO2, affects SaO2. How much oxygen is there in the blood? It is best depicted by arterial oxygen content, which is defined as hemoglobin into 1.34 into arterial oxygen saturation plus 0.003 into partial pressure of oxygen. Now respiratory alkalosis. How the body responds to the respiratory alkalosis. In acute respiratory alkalosis, immediate response to fall in CO2 and H2CO3 leads to release of H plus by the blood and tissue buffers, which reacts with bicarbonate when there is a fall in bicarbonate level and there is a fall in pH. Cellular uptake of bicarbonate in exchange for chloride occurs and the steady state is reached in 15 minutes and it persists for 6 hours. After 6 hours, kidney begins to excrete bicarbonate. The steady state is reached in 1.5 to 3 days. The timing of onset of hypocapnia usually is not known except for a patient on mechanical ventilation. Hence, the progression to subacute and chronic respiratory alkalosis is indistinct in clinical practice. Treatment of respiratory alkalosis. Respiratory alkalosis by itself is not a cause for respiratory failure unless the there is an excessive increase in work of breathing. So you have to treat the underlying cause. Usually, extent of alkalemia is not dangerous. Administration of O2 might be required if the patient is hypoxemic. If pH is more than 7.55, the patient may be sedated, anesthetized, or paralyzed, or put on a mechanical ventilation. This is a pseudo-respiratory alkalosis which is commonly encountered in patients undergoing CPR. Respiratory acidosis. Now, body response, immediate response to respiratory acidosis to rise in CO2 is blood and tissue buffers take up H plus ions, H2CO3 dissociates and bicarbonate increases with rise in pH. The steady state is reached in 10 minutes and it lasts for 8 hours. After 8 hours, kidney generate bicarbonate. The steady state is reached in 3 to 5 days. The treatment of respiratory acidosis is ensuring the adequate oxygenation. The care is to avoid inadequate oxygenation while preventing worsening of hypercapnia due to suppression of hypoxemic respiratory drive. You have to correct the underlying disorder and also avoid the rapid decrease in chronically elevated CO2 to avoid post-hypercapnic metabolic alkalosis. Metabolic acidosis. The metabolic acidosis, the pathophysiology is bicarbonate loss either through renal tract or GI tract. There is a decrease of renal acid secretion. There is an increased production of non-volatile acids like keto acids, lactates, poisoning, or exogenous acids. The cause is ketoacidosis, which occurs during diabetic ketoacidosis, alcoholic patients, starvation, in lactic acidosis, and in toxicity with salicylates, methanol, ethylene glycol, and paraldehyde poisoning, and renal failure and rhabdomyolysis. The causes of normal anion-gap metabolic acidosis is bicarbonate loss through GIT, as in diarrhea, in pancreatic or biliary drainage, or in urinary diversion like ureterosigmoidostomy, or in renal conditions like proximal type 2 renal tubular acidosis, ketoacidosis, or post-chronic hypocapnia. Now, evaluation of metabolic acidosis is done through serum anion gap and urinary anion gap. As you all know, anion gap is the difference of unmeasured anions and unmeasured cations. The serum anion gap and urinary anion gap is used to distinguish GI from the renal causes of loss of bicarbonate by estimating the urinary ammonium levels, which is elevated in GI bicarbonate loss but low in distal renal tubular acidosis. Hence, negative urinary anion gap seen in GI tract loss of GI bicarbonate loss, while it is positive which is seen in urinary bicarbonate loss. So, if there is a metabolic acidosis and the anion gap is increased, then if ketones are positive, then it is ketoacidosis. If plasma osmolar gap is also increased with increase in anion gap, then it is intoxication. If increase in anion gap is with increase in serum lactate, then it is lactic acidosis. If it is ketoacidosis, if beta hydroxybutyric acid to acetoacetate level is more than 5:1 ratio, then it is alcoholic. If beta hydroxybutyric to acetoacetate level is 3:1, then it is DKA. If the metabolic acidosis is with normal anion gap, then you have to go for urinary anion gap. If urinary anion gap is positive, then it is renal tubular acidosis. If urinary anion gap is negative, then you go for urinary osmolar gap. If it is normal, then it is GI issues. If urinary osmolar gap is increased, then it is iatrogenic acid gain. Now in renal tubular acidosis, if the urinary pH is more than 5.5, then it is type 1 renal tubular acidosis, and if urinary pH is less than 5.5 with hypokalemia, then it is type 2 renal tubular acidosis, and if urinary pH is less than 5.5 with hyperkalemia, then it is type 4 renal tubular acidosis. Now the treatment of metabolic acidosis, the when to treat is very important. If it is a severe acidemia, then the cardiac function might be compromised, so you need to treat. Usually a pH of less than 7.2 needs the treatment with bicarbonic acid, with soda bicarb, because the contractile force of LV decreases. How to treat? The treating the underlying cause, then there is a bicarbonate therapy. The aim is to bring the pH to 7.2 and bicarbonate to 10 millicurie per liter. How much bicarbonate to be given? So how much soda bicarb to be given is 0.5 into body weight into bicarbonate deficit. And why not to treat excessive with soda bicarb is because based on the because the increase if excessive soda bicarb is given, then there is an increase in CO2 production from bicarbonic acid decomposition, which leads to hypercarbia, especially when pulmonary ventilation is impaired. Also, it leads to myocardial hypercarbia, which causes myocardial acidosis and impaired myocardial contractility and decreased cardiac output. Also, excessive or soda bicarb use may lead to decrease of SVR and coronary artery perfusion. Also, it leads to hypernatremia and hyperosmolarity, which causes volume expansion and fluid overload, especially in patients with heart failure. Also, there might be intracellular acidosis, paradoxical acidosis, especially in liver and CNS patients. Excessive soda bicarb may also lead to excess gut lactate production, decreased hepatic lactate excretion, and thus increase in serum lactates. Now, there are the other drugs which may be used instead of soda bicarb, like carbicarb and tham. Then there is a metabolic alkalosis, the fourth condition. It is the most common condition encountered. Severe metabolic alkalosis is associated with significant mortality. If arterial pH is of 7.45 leads to mortality rate of 45%, arterial blood pH of 7.65 might lead to the mortality rate up to 80%. The metabolic alkalosis is classified by response to therapy or underlying pathophysiology. The initiating event might be bicarbonate gain or the H plus loss through renal GI tract, or H plus shift, or contraction or chloride depletion, volume contraction or chloride depletion. Maintenance. Alkaline loads generally are excreted quickly and they are easily by kidney. Significant metabolic alkalosis can thus only occur if the setting of impaired bicarbonate excretion. Impaired bicarbonate excretion occurs when there is a decrease in GFR, volume depletion, increased reabsorption as in volume and chloride depletion, and hyperaldosteronism. Pathophysiological classification of metabolic alkalosis is H plus loss in GI causes, renal causes, or bicarbonate retention as in massive blood transfusion, ingestion milk alkali syndrome, or administration of large amount of soda bicarb. There is a contraction alkalosis as in occurs in patients with diuresis or loss of high chloride, low bicarbonate GI secretions as in some diarrheal states. The fourth one is H plus movement into the cells which occurs during hypokalemia or refeeding. Now, classification of the causes of metabolic alkalosis according to response to therapy. If it is volume and saline responsive, saline responsive which occurs during volume contraction and chloride depletion status, then as in gastric losses or in diuresis or diarrheal states, the or in cystic fibrosis. Okay. The classification of the causes of metabolic alkalosis according to response to therapy, as in volume or saline responsive, like conditions like gastric losses or diuretics or diarrheal states, or in cystic fibrosis. If it is a potassium depletion, mineralocorticoid excess, like in primary hyperaldosteronism or apparent mineralocorticoid excess, secondary hyperaldosteronism, like in primary causes, secondary causes, or the exogenous causes, hypercalcemic states, and other causes like carbamazepine, ampicillin, and penicillin use excess, bicarbonate ingestion, etc. The manifestations of metabolic alkalosis are the various systemic manifestations occurs with like arterial constriction, reduction in coronary blood flow, predisposition to refractory ventricular arrhythmias, respiratory perturbations like hypoventilation and hypoxemia. Metabolic conditions, it may lead to stimulation of anaerobic glycolysis and organic acid production. Cerebral manifestations like reduction in cerebral blood flow, mental status changes. This may lead to tetany, hyperreflexia, and seizures. Evaluating the metabolic alkalosis. Urinary chloride and potassium measurements are done before therapy, useful diagnostically. Low serum chloride, if it is less than 10 mg per liter, seen in alcoholic states where chloride depletion predominates. It remains low until chloride repletion nearly is complete. A urinary potassium concentration of greater than 30 mg per liter with serum potassium less, with decreased serum potassium suggests renal potassium wasting due to either intrinsic renal defect, diuretics, or high circulating aldosterone. If urinary potassium concentration is less than 20 mg per liter with decreased serum potassium suggests external potassium loss. Now, treating the metabolic alkalosis. The metabolic alkalosis are treated according to the form of metabolic alkalosis. If it is a volume depleted and saline responsive metabolic alkalosis, the it is done by depletion of both chloride and extracellular fluid volume. It is most common. Then it is replaced with isotonic NaCl, isotonic saline. Also you have to replace continuing fluid or electrolyte loss. Also correction of sodium, potassium, and chloride deficit is needed. If depletion of chloride and there is a depletion of chloride but increase in extracellular fluid volume, then you may need to administer sodium chloride. However, administration of sodium chloride is inadvisable for obvious reasons. Because chloride should be repleted as KCl unless hyperkalemia presents or concomitant decrease of GFR when ability to excrete potassium load is hampered. Administration of acetazolamide accelerates bicarbonate, especially if natriuresis with a high sodium excretion rate is required, simultaneously if high serum potassium is also present. However, the monitoring is needed to detect associated potassium loss and phosphaturia. GFR must be adequate. Acetazolamide is contraindicated if serum creatinine is more than 4 mg per d. Chloride depletion with increase of ECF volume and hyperkalemic state, then you may need to give hydrochloric acid. Dialysis might be useful in the presence of renal failure or severe fluid overload state in congestive heart failure. Dialysis with or without ultrafiltration may be required to exchange bicarbonate for chloride and correct metabolic alkalosis. However, usually the dialysis for both HD and peritoneal dialysis contains high bicarbonate or its metabolic precursors, and their concentration must be reduced. In patients with unstable hemodynamics, you may need to have continuous venous hemodialysis using NaCl as replacement solution. Adjunctive therapy are proton pump inhibitor. Now, treatment of volume repeat and saline unresponsive metabolic alkalosis is you can use spironolactone, which is a potassium sparing diuretics. You can have a restriction of sodium and addition of potassium to the diet. Now, the summary of entire presentation is you need to have a serial ABGs which needs to be correlated with the clinical profile of the patient, and it has to be supported by the lab data and investigating tools, and by all these three mechanisms, by all these three steps, a clinician takes the judgment and a correct interpretation is done, whether it is a simple disorder or it is a mixed disorder, or it is a oxygenation or ventilatory status needs to be assessed. Thank you.